Okay, now I think we're live. Yes, we're live. Hey, look at all you people who came back to here and watch some more of the coding, dramatics, theatrics, and all kinds of antics. Just kidding. This will be, for certainly, the most serious discussion I have ever had. Okay, that's a lie. I don't have serious discussions. The topic of tonight's discussion is going to be the powerhouse of all things surgical, generally speaking, general surgery speaking. So, without further rambling, let's introduce our panelists who at one point had the urge to surge. Yes, that was awful, and I did have to write that and put that in there. Yeah, it was bad. So, we have two panelists with today. We have Monica Akutch, who will be speaking. Oh, let's put the banner up. Banner it is. Mark Kutch, who is a surgical coder for the Sarasota Memorial Healthcare System and a surgical coder for the Surgical Associates of Venice and Englewood, which is SAVE in Florida. She also has a third job, which we're not going to mention, but it's something to do with clinical documentation improvement. And we have Sandy Jean Greco-Brown, MHA, RHIT, Alana Alphabet Soup, but she's the Director of Revenue and Coding at CLA, and they're going to talk from their experience in general surgery coding. So without further ado, let's step right into this pile. Let's talk about what general surgery entails. Let me turn off the banner. What are some of the common conditions and common services performed? And I know there's a lot. This is a wide, long, super answer. But Sandy, do you want to go ahead and start with what you see commonly being done in general surgery practices?
Sure. It can be, like you were saying, John, a wide variety of things. And it also depends upon the facility as far as what the provider may be doing as well. So it may be that you have some specialists that kind of take over some of those different areas. But I typically think of it as kind of almost head to toe, that they can be doing everything from lipoma removals to thyroidectomies and other things as well. So and of course your gallbladders and such, they can be working on all the different body parts. And it just really depends. I know there have been some clients that I'm familiar with that the general surgeons, are on call more frequently. And they're doing a lot of hernia repairs, especially if the patient should come in urgently and need emergency surgery. But I think it's just a wide variety. And I think that that's the cool part about general surgery, is that you do have to have a wide breadth of knowledge there that I know we'll talk about as well. So.
And Monica, you're up.
Yes.
General surgery, what does it mean to you?
It's a lot. It's lap choles, open choles. It's also lesion and also removal of the small tumor lipomas, from the small procedures to big or procedures. We can have a little bit INDs, which is incision and drainage. We can have a little bit toes amputations. Everything falls in that general surgery. They come and see us, and our physician evaluate them. They have a consultation. They're getting second opinion. So it's a lot. It's a great specialty to start.
Okay. So now there's a can of worms I want to open up early, just because everybody's excited to hear this. I know at least I am. But what are some of the craziest, most off-the-wall surgeries you've seen, like in any GS or general surgery setting? Like some of the weirdest things, and if it's kind of personal or in a very private part of the body, maybe we'll skip that. But let's talk about some crazy cases, because we've seen them. Some we don't want to talk about, but some are interesting. What's something you can think that really stuck in your mind as like, man, that must have hurt?
Yes, I love the colons. The colons are very interesting, how they cutting them. What colon is connected to the other colon? We have a small bowel, we have a big bowel, we have ascending, we have a colostomy, we have application, we have a physician that comes and cut on the side and do the application of the colon. It's very interesting. And we work with our physician hand to hand. When I start coding for general surgery, I literally asked them and I said, what else is left in the body? I can't even picture that. And they take the piece of paper and they literally draw you. This is the ascending colon. This was connected to the terminal ileum. Then we went on the other side. We created colostomy for that. Oh, other bypass, enteroenterostomy, brow enteroenterostomy. So it's very interesting. Some of the patients come and they have already altered anatomy. You have to kind of pictures. We did resect that, ileocolostomy or colocolostomy or coloproctor, and then we redone the surgery. So the altered anatomy is sometimes very difficult to picture. So I usually work with my physician, other senior coders, and I ask them, you see what I see? I look at the path report. I pull up all other medical records that I can see what exactly was done to, assign accurately the CPT and the code.
How you said? You say anything weird in your travels in general surgery?
I would have to agree that I like the lap choles and stuff too, and to think about some of the different procedures that you can have with that, with the providers looking for those stones and being able to see if there are some residual stones.
Yes.
I find it fascinating, and I don't think I even realized, even as a patient, that you can still have some of those stones left over in there that they may not even be able to see, and unfortunately you could even pass those years later. And I feel like it's the gift that keeps on giving, right? When you have a bad when you have a bad chole, or a bad gallbladder, the fact that even if they take it out, that you still can have some additional stones that are in there. And I find that fascinating, and to be able to read in there. And I know, on a personal level, when I had mine out, I knew the surgeon, and even my family practitioner. He was in and did an assist because it was a pretty small facility. And I remember them saying that, they saw scar tissue of where I had passed some of the
Oh,
stones. And then they said, oh, and we saw some other stones that would have been really fun for you to pass too. And so we're glad we got those out for you. And I was thankful, because the ones I had passed were just not pleasant at all. Not at all. So I find it fascinating though. And I think I like the fact that we can do some of those interventional radiology procedures along with that, and thinking about that. And going on to what Monica said, just some of the different things that they can connect and reconnect. And I'm a visual person, so I'm much like Monica. I'm going to get it out. I'm going to be able to look at it. I may even
yes.
Google it. Yeah. To see what is this that they're connecting, and what are they looking at? And I feel like that's really what we have to do, to be able to just get a good feel for what we're seeing, and so we can understand it. And then, I always feel like too, if we're going to go back and ask the provider a question, I need to educate myself and make sure
Yes.
that I've done that research before we go back and embarrass ourselves. So it's always so much better when we can prepare and go back and say, we saw this, I read this. Is this what you did? Because this doesn't seem like it fit into this code, or in this situations where our provider could have been doing that additional work, and maybe it does qualify for the modifier 22 to be added on. Yeah. So having that kind of conversation with them, just being able to know, like, this is what the typical time and work is, and wow, it looks like it was extensive, above and beyond. And that's what I see too, John, when I do audits. And I love to be able to go back to our clients and say, hey, I actually saw where this provider documented beautifully what they did, but no one caught it, that we could have added on that 22. So being able to have those types of conversations and not so punitive, but being able to think about additional reimbursement.
Okay. When you mentioned 22, just for clarification, that's modifier 22, right? Then
Correct.
that, I think that's what prolonged services, or like
22 will be increased the service. Usually they pay maybe 20% extra. A lot of those payers right now, they require you to the extra documented time. How much longer it was the different lab coli. And you know what? Speaking of that, every lab coli is different lab coli. It's not the same. Everybody has a different body. It takes us a little bit longer, and maybe other patients have a comorbidities, or maybe it's obese and it takes them longer, or frozen abdomen. So those are the things that would qualify for additional time 22, and write the letter and said, hey, provider spend it 45 minutes in addition to the license of adhesion. It took him that long to safely proceed with the lap chole or even colectomy. So those are the things that they're looking for. It is great to work with them to know and capture the additional bucks for that work.
Yes. And I'll just add on a little story to that. My dear friend, Kim Huey, I know she shared this because we've done lots of education on general surgery together. And, she used to work as a general surgeon coder, and she still does. Actually, she does that on the side, and she loves it because it keeps her skills fresh. And she said that she was working with a provider once that he called them hernia operations and such. He was so cute. And she said that, he came and talked to her and said, this one took me so
Yes.
much longer, and, it was much more work and such. So they talked about it, and it actually took him 3 times as long as it did typically. So she actually tripled the charge and billed it, and his documentation was top notch and just really outlined that. And that's her best story about, she was able to get 3 times the payment for that because he had documented, like Monica said, the time of this is what it typically is. And then it took that much longer and why it took that much longer. So, and gave great descriptions. So that's always a story I love to share with folks. And I know Kim would be flattered that I shared that about it, because it's just one of those things where it's best case scenario. And that's when you can get your providers to really document it well.
Yes.
It can be great. So yes.
All right. So flip side question. So there's a lot of topics out there, a lot of surgeries that are interesting. Is there anything that like you really hate seeing? Like, is there any surgeries that come across your desk and you're like, oh, I don't want to touch that?
No, absolutely no. I love it. Every case is beautiful. Every case is different. I love every single case. Sometimes you spend time a little bit longer. You just have to sleep on it, put it aside, come back next day, reread it, and it's like, oh my gosh, I got this. I got this. This is it. And it's funny because we only have the CPT manual and we have a one code, but one provider takes, 4 centimeters of the colon, other provider takes 20 centimeters. It's the same code. That's, it's amazing. It's just, that's where we are.
Yeah. So, I mean, this is a situation where unless you're ready for it, this could be a very gruesome kind of job. It's like, anything that like you've seen them possibly is like thought, that's bad. That's or just makes you nauseous. I mean, I have my cases that I see. I work with a lot of urology, and hold on, I'm sorry, I need a minute. I see a lot of corpus callosum fractures, and they're not fractures, but those kind of cases get to me. No. But if you're new coder and you're not ready for some of that stuff, you get that gag reflex because it just, like you can picture. I don't ever want that to happen to me. because a lot of the things that happen in general surgery, they can be planned surgeries, but sometimes they happen in the ER, right? Like you might see your general surgeon might have hospital privileges, and they might handle some things that are outside the norm. So with that, keep in mind that if you're a new coder and you're looking into this field, might take a strong stomach reading some of these notes. And that's where it could be hard. Like you might have to take a few minutes to breathe. Sometimes the patient doesn't make it. A lot of times they do.
That's hard.
Yeah.
So from that stance, this is a great field. There's a lot of work, and this is where you get a feel for a lot of different specialties. I consider a general surgery to be the gateway, a certification for a lot of other specialties, because they all intermingle. So I know there's derm, there's what are some other kind of things you would see? There's a lot of derm, a lot of GI,
vascular, a lot of general vascular. We create a AV fistula for the patients. They have a renal disease, so they put in central lines, they revise the capsule. So the general surgery is very, very big. It's a great specialty to start. As soon as you get grasp on it, it's really interesting. It's like you want it more and more and more. It's so fascinating. It's every case is different.
Yeah, I would agree. And I think also thinking about the different specialties that they really touch, because as Monica was saying, you have everything from vascular to dermatologic to endocrine to the colon. They really do. And you think about that with the body, they really do have to know. And as coders, we really do want to have a really good background in many of the body areas, because if we don't, we're going to have some ramp up time, and that's okay. That's okay. Too, because we all have to learn, but really understanding that and understanding, I know, the different parts of the thyroid, the top and the bottom, and the ipsilateral, parts, and the isthmus, and sometimes they take it, sometimes they don't. And so you really have to be able to read the notes clearly to understand what are they doing and where are they taking it from. And like you were saying, John, not only reading the notes, but I've accidentally clicked on, even today, I'll be auditing and I'm like, oh, pictures, oh, mercy. So you have to be sure that you can stomach those as well, because and yet sometimes I appreciate the visualization, especially if we're doing colonoscopies and the provider tells me how far in they went, or I can see where they did the biopsy in the colon. That, for my visual brain, that really helps me to be able to know. So I don't mind the pictures. Of course, I was an EMT for 20 years, so I saw some body parts and things that I don't know that I necessarily would have. It doesn't mean that it makes you immune by any means. There are still some times when I'm like, oh, wow, that is still shocking. So,
yeah. And sometimes the OpNote doesn't do it it doesn't make any comparisons. So the OpNote could tell you what happened, but until you see the image, you have no idea the extent. Yes. I do a lot of vascular, and with vascular, there's a lot of wound care, and a lot of what they say ulcer, and that's a very I want to say meek term, but a very gentle term, ulcer. Until you see the photos, when the ulcer is like this big, and it's purple, and it's orange, and it's blue, and
it's down to the bone, and
it's in the bone. Yes, that's part. Yep.
Yeah, I try to avoid clicking on the pictures, folks. Yeah, no, I'm good with just the OpNote. My goal is to get the provider to write it up well. Make sure they don't have to look at the pictures. Do them a favor.
Yes. Speaking of wound, though, John, I've been doing a lot of wound wound care lately and a
Oh,
lot of wound care audits, and I've been looking at a lot of those. So I have a fond appreciation of wound care recently. It's like I feel like it goes in spurts, where I'll have a bunch of one thing and then, oh, wound care seems to be my big thing right now. So,
And just to point this out, like if you're doing treatments and wound care, you'll see a lot of that. But
mhm.
when you have a wound vac that's more than 50 square centimeters,
Oof.
yeah.
50 square centimeters is a pretty big plot of land. And sometimes it doesn't click. Like 50 square centimeters is like your entire chest. And
Mhm.
that's if the wound is that big, like your skin is like pretty much gone. So like
Yeah.
whenever you say that they document like 32 square centimeters, draw that out. Get a
Right.
ruler and say,
Mhm.
that's something that might point you into like medical necessity and severity, because sometimes we see the 1 by 1 centimeter. Yeah, we know that's tiny, but sometimes you can't get the true picture by reading the notes. Sometimes these numbers don't really give you the right perspective, but drawing it out sometimes does.
Yeah,
Absolutely.
I agree. Also, if the patients comes to the wound care clinic, they actually snapping those pictures with the measurements, and when they come
Mhm.
in, you see the big
Mhm.
black foam, shrink with the drain on it, and with the canister they coming in sometimes. Yes, I agree. That could be a little bit hard to see.
And with a lot of general surgery, like you have to pay attention to the numbers. If they're
Mhm.
doing
Yes.
Yes.
anesthesia, sometimes they have to keep track of how long to do an anesthesia for, if it's general, if it's not. Um, but also blood loss. Sometimes they say that they had like one, there was like what 25 milliliters of blood loss. Sometimes it's like 518 milliliters. That's 5 liters of blood. I don't think the human body has that much, but like if you got to consider how much blood is lost during procedure, sometimes they'll put minimal, but that also could be some context that might point you toward high severity, or give further context about how bad the patient was. Um,
Yes.
so let's get away from the gory details. I know we'll come back to it later just because I'm a sucker for this stuff. Um, what are some of the other big issues with anatomy that a coder should take steps to prepare for? Not just knowing it, but you know, there's a lot of info to learn, right? Like you really have to know your stuff. And I'll let you guys just take this one. What what are some things that people that want to learn general surgery need to like ramp their knowledge up on before they begin?
Well, I think definitely anatomy is a key in order to code correctly and see it, like what part of the colon. Then also there's several additional add-on codes that we can capture, like
Mhm.
mobilization of splenic flexure, or creating the omental flap. That sometimes the PTP edits or NCCI edits doesn't allow us to rebundle that, doesn't allow us to put additional code, but we're capable to capture that additional work through the add-on codes. So anatomy, hepatic, flexure, splenic flexure, which hepatic flexure is now billable, splenic flexure is billable. So that anatomy is actually crucial in order to assign additional reimbursement, additional code. Not only that, but just it's like a language. In more
Mhm.
codes you add, then you painting the pictures. If we will actually put it two cases with all the codes together, you could actually name it. Oh, this one had it like this one had a cancer because this one has this one has a, like diverticulitis, this one also had a colostomy, colostomy. So we took that down. Maybe we need to know, was it that reversal with the colorectal anastomosis added in colorectal? So we need to know what it that means for us. So it's really fascinating, but I love the YouTube pictures. I go in and I see the small procedures. And again, if I don't understand, I asking the people and I say, can you take a look? Do you see what I see? And it's great because if you have all the other coders and they look at it and said, Monica, you're looking too much. Oh, they would say, no, no, I really see that happened. They did the colorectal, reversal. So that's for me. And again, every case is different for me. I love coding. It's my passion. I spend a lot of time doing the research, connecting to the people. And if I don't know, I will sit and I will even call the insurance and said, hey, I'm getting denial. I don't know. I mean, what can I do with that? Or I'm reaching to senior coders and said, I coded this way. What happened? Where is the breakdown? It's amazing because it's not only coding, you also require the knowledge for the billing, which
Mhm.
all payers are different. They require different billing, different modifiers, whoever pays 50, whoever pay right and left. So it's amazing. It works like a clock, like all together. It brings the whole entire pictures and satisfaction.
So we have a chat question. This is going to be like a pretty on the spot kind of coding thing, but uh, somebody in the chat asks this. They use a scope now for hernia surgery, which is laparoscopic. It takes less time to recover wound wise. Does the hernia mesh have any kind of billable code? Because I know sometimes you can bill for mesh, sometimes you can't. I
Mhm.
think there are a few criteria for that. Like, what would it be? Like, what location and right?
I think used to be billable, used to be add-on code to capture the mesh. However, all new coding came and that hernia was revised. Either is open and
Mhm.
laparoscopically and includes the mesh. But what is important right now is that all providers document defect and what kind of type of the hernia and how defect was be, it's big. That's what's the driving right now. All the CPT for the hernia repair codes. Parastomal hernia has a new codes as well. So that section was revised this year. I don't believe we are having additional code for placing the mesh, but we do have, if the incisional hernia happen, we have an additional code for removal of that mesh.
Yeah, and I was going to say, Monica, and isn't there a code too for if the mesh becomes infected? So if the patient ends up having the mesh placed, but then they have complications of it, I thought that I had recently audited record that it was infected, and the provider did a good job of capturing that. But it's been a minute since I've looked at that note. But I thought that there was a code for that, that if you have to go in and take that out, kind of like if we have a foreign body or, if we put something in, it
Yeah,
to
I
me,
think
yeah.
Yeah, I think it was in the 20680, like the
Mhm.
removal of the implant infected,
Yes.
because the add-on code that I'm actually, which one I was talking about, is a 49623, and it's a removal of total or near total non-infected mesh. So
Yes.
I think also the great website that I go, it's the General Surgeon Bulletin. And I think you're right. That was damage control surgery describe how to code with the 52 and 58 when the provider takes the patients back. I'm not able to close the belly due to any circumstances or condition. And I think they did suggest it. I believe it's a 2680. It's a removal of the implant, mesh implant. Yes, I think, yes, we can get paid for that.
Yeah. Which I find it fascinating to just think about that. So, and I saw that someone mentioned that they are interested in taking the general surgery exam. And I definitely encourage that. And this, I think, would be helpful. And I think it's helpful too to just think about the different parts of the body and being familiar, as John was saying too. I remember being very new to CPT coding and really learning it. And one of the best visual things, because okay, I'm going to show my age, you guys, but the internet wasn't as robust as it is now. So we might have used it just for email things, and we didn't have, YouTube and things like that.
Yes.
So I remember purchasing, and I still have it on my shelf, the Netter's book, where it had the atlas of human anatomy, and then it broke down, the components of the different codes and such. And I I had to use that when I first started, and just because I just wasn't as familiar with the CPT codes, especially. I knew more of the anatomy because I had had that in my education throughout the years, but it was something that I needed to be able to bring those two things together. And so that for me, being able to see, okay, this is, a great picture. And then if you're taking these pieces out or you're doing this, it could be these different CPT codes. So yeah, there's great tools that thankfully someone shared that with me as well. It was helpful. So
I'm sure nowadays there's a lot of tools as well that are out there that are great, and they're probably give you a lot more added benefit than hanging around in ER or, you know, uh, cutting up people. I'm sure there's better ways of getting that insight. What kind of tools, besides netters, do you think are out there? I've watched things on YouTube. Usually I can probably do about a minute of that and then I'm done. But I'm sure there's other. I can think right off the bat. I know on Codify, like they have
Yes.
a lot of like images of like the major part of the surgery, like and even in this CPT book, you might have a lot of occasional illustrations for like what happens. Um, but like, what are some other good places to get that information?
Well, I don't. I think also, we didn't mention that, but in general surgery, the E&M, it's a big portion
Mhm.
of it. So you got to be like almost behind the surgery because you're going to be able to capture that 25, 57 modifiers, and get paid right away, so you don't wait for that. I use Global Calculator for that. So there's a great, it's free for everybody. When you just go into Google and punch the Global Calculator, it comes up. You can plug the code and give you the, global part of that particular code. Is it 90 days? Is it 25? You can put the date of the surgery. It will calculate the 90 days for you because obviously when the patient goes back, it is important to assign the right modifiers. Is it on plan return?
Mhm.
Maybe it's a stage procedure. So those numbers all counts for us. So the global calculator, it's for free. Everybody can access that and it's great. I use it every day.
So there's a lot of added complexity, and you were mentioning a lot of the modifiers. So let's throw a mock scenario out there. So patients walking home from I don't know, playing basketball, and they cross the road, they get hit by a bus. Okay, multiple leg fractures, ruptured spleen, lacerations all over the body, lot of stuff going on.
Yes.
Kind of covers a lot of ground in general surgery. So you have minor lacerations, which may have a very,
10
I would say,
days. Yeah.
it could be a very small global period. The leg fractures are going to be like a 90-day, right? But if there's any ongoing care, that means like anything related to the wound care for the lacerations could be coverable beyond 10 days. Whereas the leg fractures, like you're gonna get paid once for like the whole 90 days unless something outrageous happens again, right? Like he's
Yeah, the non-healing ones. I mean, we have the global package, and it's very clearly defined by CMS. We get this one E&M to assess this patient. Putting modifier, and we're doing the decision of the surgery. Um, the person that walk on the street that got hit, I see like it's a more like a trauma call for me. They're bringing him in. We have an orthopedic team coming in, doing the fracture. We have a general surgeon coming in, taking care maybe of the spleen. And maybe the patient has additional condition and we already know the wounds won't be healing. Maybe they have diabetes and it's going to be prolonged care for that patient. They're going to come in and we may have to do the debridement. And, some of those codes don't have any global. They don't hit against anything. We can actually able to capture that. We can do excisional, subcutaneous. We can do to the muscle, even bone debridement, 110404. I mean, they do not have a really global. I mean, and again, it comes to the payer again. Who is going to pay and who has the, billing policy, and requirements, what can be billed for each payer. I'm
Yeah.
not sure if I answered the question.
Yeah, I mean, there's a lot of overlap too that we have to be careful because with general surgery, a lot of times you can get paid for for wound closure, like they have a laceration to be closed, unless it's part of a larger problem, like if they have the leg fracture, God forbid, and that bone comes right out. Well, they gotta close the skin too, but that's part of the wound. That's part of the leg repair. But if you have a laceration, say on your head, which is completely unrelated to that leg fracture,
Fracture,
unless
yes.
by chance, when you got hit by the bus, that piece of bone fragment ended up in your face. But even then, there's ways around. That's a completely different,
Private
outside of
parts.
the norm. But you being able to identify what's paid and what's not, because you can have a lot of stuff. Like I always try to come up with these crazy situations, like you know is this payable in the situation or is it not, because you really have to think about it. And that's where if that note you're reading isn't very clear as to where that laceration was or where the closure was done, it may be payable, it might not. You might have to ask for clarification.
That's correct.
um,
Mm-hmm.
I mean that there's a lot going on in general surgeries. Like it takes a lot of, I think it takes a lot of key focus when you're reading a note, especially when you have those high-end cases. Now, if a patient comes in because they have a mole removed, pretty cut and dry, no pun intended. But sometimes these ER visits can get a little complicated, and that's where the modifiers come in. So I think that's where you're headed with this. You need to know key specifics about what can get paid using a modifier and what can't, even with a modifier.
And also distinguish, John, like you said, is a leg and head. Do I need a 79? Do I need a right? Do I need a
Mm-hmm.
left? I need to identify everything, the multiple procedures, what's allowed, and qualify for that. What we have a codes there, they're exempt on 51 too. So yes, it's a lot. It's sometimes, those trauma patients takes a little longer to, code and take a look at it and said, okay, this was done. Now we have a laceration of the head that is, not, you know, um, included in the leg. So that can be coded separately. Then we have another laceration, maybe on the shoulder. That also is not included in a fracture leg. So everything, small procedure has this 10 days global, bigger procedures has a 90s, but you still have to add it, the laterality and the other modifier, what's, billable or what's not. And by adding the 78, 79, right and left, and 51, we actually showing payer what happened to this case.
Yeah. How about you, Sandy? You want to add anything into that? I mean, I'm thinking of like with the what's that thing called, the NCCIs?
Mm-hmm.
That's also an important tool to have. I don't know if you want to get into that, but that's something that you have to get very familiar with when you're doing a lot of surgical stuff.
Yes. And just adding on to it, I mean, Monica can spit these out beautifully, but that's really something where folks need to really, really get comfortable with those NCCI edits and what do they mean and when can you and when is it appropriate? I've been doing this a long time and I know I've seen people and I've done education sessions where people will say, oh, we just put a 59 on there and we get paid every time. And that just makes me cringe because that's great that you're getting paid for it. That doesn't mean you're going to get to keep that money. So good luck. And I hope that your documentation actually supports it. But it is one of those things where we do need to be able to read the note and know, yes, this does support, the two separate areas and two separate things that were done today. And yes, it would be appropriate then to put on the modifier 59 versus, we just figured out we can just bypass that edit and it's no problem. It's not a problem yet or now, but it could be. And we always want to think about the fact that I don't want providers or practices or hospitals or anyone to have to pay back money So from a compliance perspective, really making sure that our documentation does meet it. And speaking of the NCCI edits, the manual that comes with that is fantastic. And I think a lot of folks don't realize that there actually is a manual. You know, some of us have just kind of learned, or we know how to go out to the CMS website and be able to find those edits. But being able to actually look at the manual, and it has some great examples in it. Excuse me. And I would just encourage folks to go look at that.
Yeah. And like it explains like what a lot of the allowances are. And there's a small difference from what I understand. And this is where it takes a lot of practice. But when you're learning coding, you learn here's our CPT manual. You know, here's what the code descriptions are. That's written by the AMA, which is really this outside company that just writes this guidance material. Payers sometimes follow those rules. Sometimes they have their own rules. But inside the NCCIS, which is written by Medicare, you know, like who's like the overseer of a lot of plans. Like they write the rules a lot of plans agree with and say, yeah, you know, rather than write our own policy, we're gonna piggyback on what they've already done, and we're gonna agree with their policy. So what Medicare says is that yes, we agree with a lot of CPT rules, unless we say otherwise. So if we don't tell you that it's not okay, and you have to do it a certain different way, do it. They actually say in like there's like 25, I think there's like 20 chapters in the NCCI manual. It's all broken down by each different portion of the CPT manual. And the first one is the rules. Okay, so here's the core rules. We agree with CPT unless we say otherwise. So follow CPT rules unless there's something in writing from us that says you need to do it this way. And that's where the NCCI rules come in. So now they've drew the line in the sand. You need to know the rules because now this is where we're differing our position from CPT. We're getting a little more specific about what's allowed, what's not. And that's what, to me, the NCCI rules are. There's a lot of things in the CPT manual that Medicare kind of expects you to know. Like you have to know the internal provisions, like what's considered laterality. There's parenthetical guidance that they agree with. Even separate procedure designations, which kind of should learn. Yeah. So who wants to bite that one? Who wants to explain what that indicator means in the CPT book?
Well, I think it's for me it's pretty simple. It's a separate procedure as a component of the more complex, unless you can add it 59 and it's not included in the complex. Then you can go ahead and cut it. Actually, that separate procedure I believe run in the NCCI edits. They both green. You actually have to have like a PTP edits procedure to procedure in order to override it. I do believe that companion books for each specialty, they come very handy. They do explain that edits. They explain, hey, is that, procedure that can be codable as a 51? If it's, complex, if it's included in a complex code, you can code that. Those companion books come very, very handy.
Yeah, that's that's a great and other great resources as well, Monica. And then, there are some softwares out there too that can be helpful for you too. But I know for some of us, we may not have the budget, so I completely, I know, so I'm showing my age again, that when I first started doing this, we really relied on the companions because we didn't have the software. And in the world that I was in, we just maybe didn't have the access to the different encoders or, kind of some of the Optums or the Codifies or other tools. We just did not have access to those. So, and I really feel like those companions have been kept up, and they are, especially if you're new to this, they can really help you to be able to gain a better understanding of what those, when it is appropriate. And then also, I like the fact too that they explain a lot of the procedures themselves. And then I think that there's another book. I actually was looking for it, but it talks about in layperson's terms, some of the different procedures and so forth. And I think and there's also the procedural coding. That the AMA used to publish. I'm not sure if they still do, but I I haven't purchased that one in several years, but kind of the intro where it also talks about modifiers and such too. But there's great resources out there. So
Yeah. And of course, there's also the new AAPC the mag. Not to be confused with AAPC the musical or AAPC the movie, but the APC the magazine, which is where, being an AAPC member, you get a lot of articles written by experts in the field that can
yes.
explain, or there's a lot of webinars out there.
Mhm.
Local chapter meetings sometimes give you a lot of valuable information. Occasionally about surgeries, like they will have, things that are kind of, I want to say, kind of specific about like hernia repairs. Like they'll have
Mhm.
people that talk just about hernia repairs. I give presentations and like I could talk for 2 hours on hardcasts, and a lot of times that's what you want to do because that's where you get all that detailed information.
Mhm.
So like if you have a chance to listen to webinars, go to the workshops, go to chapter meetings, and a lot of times they're free. You just
Yes.
have to do a little like you have to do digging around, and find out where they are, when they are, and what those topics are. I think that there's a way to find, like, you can go on the APC website and think you can just browse through like each individual chapter, or a lot of times they'll advertise them on LinkedIn and
Mhm.
Facebook. But watch those; they're out there.
Absolutely. We had a fascinating presentation. I think it was in December in our local chapter, and it was an actual radiation oncologist. And he did a presentation about like the history of radiation oncology. And I found, even as much as I know about radiation oncology, because I've been coding it and auditing it for years, I learned things, and I didn't know some of the historical parts, the fact that they used to actually like try to radiate people without having them held down. And I mean, he even showed this picture of this child that was like bouncing, you can't imagine a 3-year-old that you could just radiate and not have them talk about not being able to focus on the tumor site or the area. So it was fascinating. And I think as much as we can try to attend those types of meetings, I love it. And that's where I feel like a lot of us really gain a better understanding. And that's when you can also figure out, especially if you're newer to coding, hey, what are some areas that are kind of interesting to me if you haven't found what you're passionate about yet? That's a great way to just kind of dabble into different things and get a great background in some things that you had no idea. I remember learning about urology coding over 10 years ago, and really the specifics that this physician assistant shared with us, I would have had no idea that that's what those codes meant. So however we can learn, it's incredible, and be lifelong learners, right? So
Yeah,
that's
it's
the fun part too.
ongoing.
Yes.
Yeah, and that's the thing about general surgery, because there's always something new to see. Like I think one of the most fascinating things, like that you see it sometimes, these procedures kind of blow your mind. So years ago, when I first started doing general surgery, like maybe 7 years ago, I saw this case. It was where the patient had, it was called an auto transplantation of their one of their glands. They had, I guess it was it their, I think it was their, not the parotid, but it was one of those small glands. Which was it? It's procedure code like a 659 something something something. Where
Parathyroid glands.
was that?
It's a parathyroid glands. It was. I think it's an add-on code, and you can implant them inside the, either arm or either sternocleidomastoid muscle, and then prevent the patients to have that. With the thyroid glands level, they can prevent those TH and T4s, and it's amazing. Yeah. I think general surgeon does it too, but a lot of times they have specialists to do it. So you go to the patients like a head and neck, and they taking, it depends if they taking like Sandy early said, it's a half of a lobe, is it a partial lobectomy, is it a total lobectomy? Then it's a great to have these pictures and take a look at it where we are, and then they can take those glands and implant them. Yes.
And I had a conversation with this provider, and it's just like kind of the medicine magic that they do. Like they take the gland out and then they grind it up. Like, picture that. Like they grind up and they reinsert it, and it works. It's like, like taking, you have a car, okay? Your engine's shot. Let's just take it out and turn it into scrap metal and just put it back into the trunk. And your engine works again. That's not how it works. But that's how this works. Like, how did somebody decide, let me try something. Let's just take it out. Let's hamburger patty this and just put it back in and see what happens. And, I'm sure there's a lot more to it, but like sometimes you see things, you're like, wow, that was, I don't know what to say. Sometimes these things like
It's amazing,
but like it's interesting to read about some of these things, like some of this, surgeries, like, and one of the things I want to mention earlier is like hernia repairs. We're talking about hernia repairs. Hernias are interesting because it's the inside of your body, and they want to go on the outside of your body, and we prevent that. But like, there are certain like rules about when you can code a hernia. So like if you go to the office and you lift your shirt up and saying, "Doc, is this a hernia?" and he pushes it back in and says, "Not anymore." There's no code for that. There's no code for saying, "Let's just fix it right now." Like you have, the hidden thumb that's poking out, and he just pushes it back in. You bill as an E&M service. It's like, really? Is that quick? Yep. It's like a bloop and it's done. But that's, some of the rules you'll see. Like, and that's sometimes that I may have spent 30 minutes trying to figure out where's the code for manual reduction of a hernia, without an open incision. There is none. So that's some of the interesting things you got to figure out. And sometimes that's where it takes practice, because that, there's a lot of stuff out there that could be an E&M service or it could be an unlisted code. So there's a lot of complexity with this, and that's where it takes a lot of reading and a lot of studying. But fascinating things, if you go with an orthopedist and your legs, and your legs is like kind of fractured,
kind of fractured,
kind of can't walk.
A little bit broken. It's the only thing that they do is like, put it back in place, and say, yeah, you're good, or if they just put a cast on it, let's say, your leg's broken, we're going to cover with plaster and we're going to send you on your way. That's still fracture repair. It's still coded like you went in with nails and screws and hammers and chisels and you treated it. Sometimes there's like, minimal work gets paid the maximum amount, but it averages out in the end. There may be days when you come in and like, as a surgeon, patient comes in and they have that leg fracture where it's splintered and the bones, they had to take fragments of bone out and they have to like, move things, take out particles of dirt. It's the same code, so sometimes the work doesn't line up, but in the end, hopefully it balances out, and that's where it's interesting, like depends on how good your provider documents. You get to see some crazy things. Sometimes they say, yeah, person came with a leg fracture. I reset the bone and I cast it and I send them home. Sometimes there's a long lyrical poem, like it's like you're reading the Iliad, and they tell you everything that they did, and that's sometimes it takes you a while to read that note, and there's still only one code, and it's the same code. It's the same code as the guy that came in and said, "Yeah, leg was fractured. I fixed it and I sent him home." That's it depends on who your doctor is.
Yeah, I think that's a big part of it too, John, is being able to decipher that, right? And to know, okay, there wasn't anything special or additional about this, or the things like Monica has shared too, on those things that are above and beyond, and when you can add on those additional things. And I know it's been something that as I've continued to learn, and I love to learn. Still, I've been in the medical field for 35 years, which I always tell people I started when I was 5. But I've been in this my entire career, and I still love to learn, and I still love to learn about things and to know, oh, this is what's going to take this from simple to complex. The provider has to document that, or we need to have this, and being able to then share that with your providers and tell them, if you tell me that it is complex and you describe why it's complex, then we're able to code this differently. And that is where I think being able to have that good relationship with your providers too is just, yeah, it's wonderful to be able to know that and to share that with them. And I think, again, doing our homework ahead of time and being able to share that information with them, they appreciate that as well, that, oh, you have a vested interest in this too. You want me to be successful and you want me to stand up to an audit. And I think providers might be surprised by that, because I spend a great deal of my time auditing, providers and coders, but I want to try to be able to give that information back to them and say, if we would have queried the provider, or if we would have seen this, so that they can think about how that might be different in the future. And if they see that again, they'll know they can code it differently.
Yeah, great points, Andy. Also, when you're querying him once, twice, three, next time they know, oh, I need to
Yes.
document that part. I need the defect. Oh, was that the cheese hernia? I mean,
Yes.
is that, can I add them together and, capture the higher RVUs and the work that they required? Because small hernia, 1 centimeter versus 5, or incarcerated, I'm sure it takes different time and different repair. That's a great example. Yes.
Yes, no, and you're right, Monica, and adding on those words are so key, and those are what we have to make sure our providers know that, and that they are clearly documenting that for us, because then that allows us to take it from what could be a simple repair to that more complex. And then it's like, oh, especially with the new hernia codes. I know I had to reach out to Kim last week because I was auditing one, and I was like, okay, I think that it should be this way. And she said, yes. So it was just a nice affirmation for me to say, okay, I think that these new codes, because they're a little bit more complex and they're a little bit more difficult to be able to determine what the provider's doing. But again, if the documentation clearly supports it, it makes it so much easier for all of us.
Definitely. And also a good point is they have no global as well. There is no
Yes.
global of any of the hernia. You can actually capture the E&Ms, that you evaluate the patients and decision of the surgery. And then when they come for follow-up, providers are capable to capture that visit, but they have to be aware it's no longer any post-op, come in, see you, your sutures are good, remove, see the nurse next time. No, those visits are actually, we are able to capture them now. That's a new thing.
Yes. And you think about that, that's more money, for the practice. So we want to make sure that they know about those things, Monica. So absolutely. And whether you're thinking about coding it or you're an office manager, these are really important things for you to recognize as well. So.
Absolutely. Prepare for the office practice. Hey, when you do the scheduling, you have an HMO plan. You may need authorization. It's no longer global. You will need to call and get the authorization for the follow-up, because we're able to capture. So I love coding. It's ongoing. It's like never ends, like a drop of the ocean. You keep going and there's always new specialty that you're learning and you're
Yes.
like, I gotta take a look at this. Like, take it back, take it books, open the, YouTube, take a look how they do it, the radiology pictures. I loved it. It's an ongoing, it's interesting, it's a great job. Um, I would say to every coder that starts, don't be overwhelmed. Just go step by step.
Mhm.
Work with somebody in the office that already have experience. They can guide you. And I would hope the new coders have somebody they can go and ask the question. They can guide them and in the right direction. Give them websites. Give them tools that are up there for free. So and just point it. Hey, take a look at it. This is 90 or 91 days because it's a pre-global day. This is 10 days. We're able to capture that. Well, we get the Blue Cross. You don't want to send it 50 to the Blue Cross. Code it right and left. Or maybe you have some other payers in your region that, they have different billing guidelines and you already know it speeds up and it helps them, to develop the passion for the coding and be successful.
Let me
Yes.
just interject real quick. There was a comment in here that there are a few people that are in the chat saying that they're not able to view the presentation any longer. If you're having issues, and you can't access this live feed, go to YouTube. Our online webcast is also being broadcast on the YouTube account. So if you're on there, and you can still hear us, go to the YouTube, visit for differential coding services, and that's the way you can watch and you begin again. And also, this is going to be available on demand. So if you are one of the ones that is actually viewing as a black screen at the moment, hopefully you can hear me. Go to the YouTube account. I'll put it on here as well. So I'm sorry about that. I didn't mean to interfere with the answering the question, but continue again. Oh, all right. So let's change the form of questioning. So let's talk about expectations. So I know this is an interesting feeling. We all want everybody to be in here. What are some of the expectations for people that want to apply for this? As a candidate, what do you look for in a new hire or a coworker? What are some things that you could recommend?
I think I think the person that can listen, the patient that is oriented to the detail, that we can capture everything. Also, the person that can take criticism and say, hey, I need to correct that. Or, you know what, we shifted a little bit in different codes. So that will be important for me that I can work with the person and develop further because coding is a big. It's so many codes and it's almost like a different language. You have to understand what they mean by that description of the code. So I would say, passion, be tolerant for the criticism, good listening, and willing to learn.
Yes. And I would say all of those things, Monica, and, just willing to be a little sponge. I remember that's what someone gave me good advice years ago. And I just have always tried to do that. If I'm around new people or a new situation, or if I have to learn something new, because we always have to, as someone put in the chat, it's great that, yes, coding is ever changing and we all need to keep up on stuff. And it is a full-time job, I think, some days just to stay caught up on things and to keep abreast of the changes. But it's so critical because we need to make sure that we are coding and billing appropriately because we don't want to either leave money on the table or become kind of a compliance issue, that we could be coding something incorrectly. And it could just be an innocent mistake, but we may not recognize the fact that the codes have changed, or it could be that the codes changed, we weren't aware of it, and now we start getting all these denials or things are getting hung up in our claim scrubber. So all kinds of different things can happen. And so we want to make sure that we're always abreast of those changes and that we know what's going on, especially in our particular area, and that we just stay aware of that. And I think, John, as you were asking too about what folks could kind of be prepared for with expectations, being very open to learning and knowing that no one's perfect, right? So we have to be able to give each other grace and understand that there will just be times when we may get it pretty close, or we may need that feedback. And especially as we're new to this, really being open to that feedback. It's something, if you're kind of a perfectionist, it may actually really kind of upset you, but we all have to be willing to give and get some feedback as well. So, and I know those are the opportunities when I have gotten feedback, when I have learned the most. And I'm like, oh, I'm never going to make that mistake again, because of whatever, if I didn't have the measurement right, or I didn't realize that it should have been complex instead of simple, or whatever the situation may be. It's those things that really get ingrained in my head then. So whatever we can do to just help us, and help each other. And I think also finding those resources, finding those reputable resources online too, and just knowing that it takes a bit, like Monica said, and it's going to take you a bit. You can't learn everything in one day, one month, or, it may be a year and you're still learning, and that's okay.
I think we all are. We're learning each day. Everything is changing. And maybe next week, Coding Clinic is going to put some articles that maybe we have to adjust in coding in different way. So it is important to work with the collector, with the billing companies, with the managers, with the other coders, and be open to take that feedback and, just learning from it, correct it, and keep going.
Absolutely. Well stated, Monica. Yes.
All right, so let's talk about advancement. So there's a lot to general surgery. So once you get your foot in the door and you've kind of learned the foundations of general surgery coding, what is the next step? Like, what can a coder do to raise themselves to the next level of coding in regards to general surgery? Simple answer, certification. But there's other things you can do. What are some of those things?
I think the easiest way will be also shifted to the different specialty. There is a closer to general surgery, like gastroenterology. I mean, sometimes general surgery will have to do the scope. We'll have to take a look if the anastomosis is, done correctly, if there is no leakage, And then you have gastroenterologists that come in and do those screenings and colonoscopies and EGDs and placement that, tube. So I think, for me was I started learning the general surgeon, then I shifted closest to one so I can advance my digestive system. And then, again, you get the vascular, the AV fistulas and central lines, and kind of go for it and go a little bit further, step further, and learn all those other specialties that are around, to get the digestive, get a little bit vascular, and then you're shifting to the other specialties. And it's so exciting.
Yes, and I would also say that if you decided, through this, that you might even prefer the auditing side, it might be, and that's kind of where I kind of took my career a little bit, only by kind of chance that it was one of those things that was presented to me, but that's where I now, do a lot of the auditing. And I would say that I am expected to know almost everything, and ramp up on things and the different pieces. If I do a general surgery audit, or if we're doing a hospital, like we do a lot of charge master reviews. So I may be auditing surgery records, but I may also be auditing injection and infusion records and clinic records and all kinds of different things. So really making sure that I have the resources that I need, and then just making sure of that. But that's one avenue you can go with as well. And then I would even say something as far as compliance, thinking about that. And there's always opportunities that maybe you decide that you want to, manage a practice. And I always feel like if you have a practice manager who understands coding, it's a bonus, because so many of them may just have a little bit of knowledge, or they may understand it's really important, and they hire the right people to do it. But there are times when I feel like if the office manager or other folks really understood this, that they would see why more education is needed, or additional resources, or they need additional coders too, and why this is critical to everyone's success.
All right. So we're coming up well past the hour. I mean, we're at about an hour 10 right now. And any last minute comments or any suggestions for coders? And does anybody in the chat in LinkedIn have any kind of questions about general surgery that, while we still have them on live, that we can answer? But any last minute chances to talk about general surgery before we move on? I'm watching the chat to see if anybody has anything. But if not, I want to thank our guests for coming and joining us today and talking about general surgery. And they will be on LinkedIn. I'm going to put up their banners again. So if you ever want to reach out to them and have questions, we have Miss Sandy Jean Greco Brown, and she'll be on LinkedIn. I think she may also be in other places. You'll see her name in articles. And if you actually do find out where that CLA is and knock on her office door, I'm sure you can have a great conversation. Monica, again, she has 3 different places that she work at, so it's a pretty much coin flip as to whether or not you'll be able to do that with her. But she's also on LinkedIn. So she's able to answer questions in regards to a lot of surgical topics from her very expansive experience currently in Florida, saving Florida, and for the Sarasota Memorial Healthcare system. We do have a comment. Let's see if this is a question. Nope, it's a thank you, good night. So I guess they're really saying, okay, wrap it up, folks. Wrap it up. All right, so next week, I don't know what's going on. I'm still trying to book people, and I'm hoping, and we need hematology and oncology coder panelists. That's my next big topic. I've had people reach out that they want hematology oncology and radiation oncology. So if you are interested, reach out to me. I'm trying to book 2 panels, one on hematology oncology and one specifically on radiation oncology. So we're looking for people to join the chat. And those are the next 2 big things. And after that, I don't know what's happening. We hope we get to those 2, but I'm still in the planning stages for hopefully next week I'll have an episode. If you tune in next Monday and there's dead air, it's because I couldn't find anybody. So hopefully you can spread the word. I'm always on the hunt for people. But if nothing comes up, we may be talking about making a great grilled cheese sandwich. Who knows? But hopefully we'll be talking about hematology, oncology, radiation oncology. But I do thank you for coming out tonight, and hopefully we'll see you next week. Have a good night, everyone.
Thank you so much, John. Yes. Thanks, everyone.
Thank you. Have a great night.
Yes.